wellness, and I'm really excited to be here tonight to chat with you all about the crossover or potential crossover with ketamine assisted psychotherapy and substance abuse treatment. A little bit of background about myself, maybe like to qualify a bit. I got my start in substance abuse treatment back in 2014. I've worked in a variety of different levels of care for substance abuse treatment, pretty much everything from detox to extended residential IOPs, number of different places. In 2018, I began working more in the clinical role. I got my master's degree, did a lot of specialization in trauma-informed care. Again, continuing to look at the crossover between trauma and addiction. And then from there, continued. Most recently, I had worked at Ashley Addiction Treatment, which is here in Havre de Grace, Maryland, where I ran a 60-day extended care program, as well as helped as a member of the clinical management team. So I guess really addiction work is in my heart. It's in my training. It's in my scope. It really is what has set me on this path. And about a year ago, I had the opportunity to join with InnerPath and begin doing some ketamine assisted work. And I remember when the news was starting to come up around ketamine as a means to treat mental health disorders, my immediate hackles went up. Being in the addiction world was just like, I don't really know about all this. And then as time went on and the research kind of compounded, I definitely got curious and started to explore what that might look like. And, a big part of the work I had been researching and trying to practice with my patients was this whole mechanism around neuroplasticity and how do we engage the brain to shift. I'm looking at addiction as a brain disease. And when I really dove into the research with ketamine, it was like, oh my gosh, this is essentially what I've been trying to do and what I've been looking for. So I continued to get really, really interested. And since then, over the past, 13, 14 months, I have worked with a number of patients who have come through InnerPath around substance use issues. And so really beginning to see in real time, like, wow, there's a lot of potential here, as well as a lot of risk. And so we're going to kind of look at the duality between how do you use a substance to help people get off substances? How do you use this as a medication? What is the line between recreational use of ketamine and psychotherapeutic use of ketamine? There's some nuances, but I do believe that it can become pretty clear cut and understood in a way that makes sense and protects the safety of yourselves and the safety of our patients while meeting different treatment goals. So fortunately, it looks like we have a small crowd tonight, so I would love, to be a bit more interactive in this process. Any questions as I go along, feel free not to wait till the end to jump in. I could probably talk for hours on addiction, and I could talk for hours on KAP. So I'm going to do my best to be concise in this process. But anyways, yeah, maybe it would also help too if anybody felt called to maybe share what sort of inspired them to come out tonight, what they're most curious about in this realm, so I can make sure to touch on the most relevant and important information for y'all. No pressure. So why don't I just start? I'll just start with kind of the basics, right? And I'm going to start with what is addiction? What are we working with? We're going to look at what is ketamine and then cross over. So a little bit of the basics. Again, my understanding and the research and my work with addiction is that addiction is a brain disease. And how do we define a disease? So looking at the medical model of a disease, looking at the disease model of addiction, you need an organ, which we can identify is the brain. We have an mismatched operation, so something that's not doing what it's supposed to be doing. So we're going to explore what those mechanisms are in the brain. And then you have consequences. What are the outcomes? What is the repercussion of these changes that are happening in the organ? So we've got the brain, we've got activation in the mesolimbic reward system. And then we have consequences that is, on a microscope look like the phenomenon of craving. So the process by which folks crave substances and begin to use substances essentially against their will, or desire or intention, and kind of get stuck in this repeated pattern of returning back to something they're desperately trying to stop. And I suppose that's the ultimate line between addiction, heavy use, recreational use, right? Is that power of choice and the power of people to choose in this process. And so that's what we're kind of looking at. And other consequences that make, addiction as a disease very taboo or culturally questionable for some is that the consequences, look like DUIs, they look like overdoses, they look like thefts, they look like ruined relationship with family, they look like all sorts of interesting pieces, or the manifestations of those symptoms are very unique for each person and their drug of choice and all those pieces. But at the end of it, it's really that phenomenon of craving that keeps people going back, especially against their will. In addition to that, each specific drug then also carries the withdrawal symptoms, which are a symptom of the fundamental brain changes that have started to occur as a result of prolonged and ongoing use with substances, right? So I'm going to use my handy dandy chalkboard here. I started using it during COVID. I was doing a lot of PowerPoint presentations and I got really burnt out. So I'm going to do my best to use it. I'm going to try to use bright colors and write really big. If you can't see it, if it doesn't make any sort of sense, please let me know, and I'll clarify or make it big. So again, we're looking at, this is my sketch of a brain here. And ta-da. So we've got back here, I'm looking at the brain stem. And I fundamentally look at the brain instead of a bilateral view to help me with this. I try to look at it from a top-down or three-region conceptualization. So in the bottom here, we have the brain stem. In the middle here, it's going to be conceptualized as the limbic system. And everything out here, for a two-dimensional model, we're going to be considering the cerebral cortex and the wraparound. If you're familiar with the hand model of the brain, one of Dan Siegel's, or I don't know if that's where I got it from, with Dan Siegel, I don't know who he got it from, but it also helps with, brainstem, limbic system, cortex, and we're going to be kind of operating on that model, right? So again, I'm talking about the mesolimbic reward system. We're also talking about dopamine, and dopamine is talked about a lot in terms of addiction, recovery, motivation, reward. It makes us feel good, but really we're going to be looking at the motivation and reward pieces. So part of the mesolimbic reward system begins in the limbic region of the brain, and it sends signals all the way through to the nucleus accumbens, which is right around here, and the anterior cingulate cortex, which is right here before crossing the orbital medial and entering into the realm of logical thought. And we're going to, I guess I'm getting a bit jumbled already. What this means is that drive, that push is coming from a subcortical area. Subcortical, for me, is another fancy, expensive way to say subconscious. I think if we went back in time, 40, 50 years, and we're talking about the subconscious, what everyone was really pointing to is subcortical limbic brain activation, right? And it gets like, how does the brain sort of know when to activate and motivate us to do different things? And a lot of that is related to memory. And memory is also a part of the limbic region. It's part of the hippocampus, which is also kind of right up in here. And so memory based on situations. So how do we know what situation we are in? Our brain uses its parietal lobe to scan all the senses, except for olfactory, that's a different place. But it all comes together in the thalamus, which is also right around here. So all sensory information as it's coming in from the body, everything I'm saying to you right now, everything you're hearing, everything in your environment is being filtered through the parietal lobe into the thalamus, at which point it then gets scanned by the hippocampus. And essentially every experience you've ever had is coming from, or is being scanned and basing itself around what's happening right now in this moment. And that's a lot of information. And that's essentially why it's a subconscious process, because it would be really, really annoying if every second we were just reliving our entire life and having to choose if there's associations involved with it. So based on the information coming in, if there is something in the environment that can either bring us towards pleasure or help us to avoid pain, the mesolimbic reward system will activate and cause us to begin to be motivated to take action and engage with or avoid something going on in the environment. So probably missed a few things. It's wildly complicated. These are the pieces that I've sort of withdrawn that help me in my clinical practice. And we'll keep going to that. So anyways,
Can I ask a question?
uh, yeah, please, thank
Okay,
you.
just thought I would chime in. I'm Shlomo, by the way.
Hi, Shlomo, I'm
Yeah.
Ryan.
Hi. Yeah. So, pleasure, pain. What about safety? Like, what about like a brain that never feels safe? How does that, you know,
Yeah, how does that
yeah,
tie in? So
yeah.
safety, uh, thanks for asking that question.
Hmm.
So safety, responsibility of measuring safety lies largely on the amygdala. And so the amygdala is a little tiny almond-shaped region of the brain that, surprise, surprise, also sits right around here, smack dab in the very middle. So all these pieces are working together. So sensory information is coming in through the parietal lobe and through our sense of smell. It's being filtered through the thalamus. The thalamus is sending it to the hippocampus. Every experience ever is being run through that. And the amygdala is standing there as a sentry. And the amygdala is standing there to say, is this safe or not? So there's a number of factors that can run into a patient never experiencing a sense of safety. Some can fall into a genetic component, and we can talk about legacy trauma, and we can talk about intergenerational trauma. There's all sorts of pieces because while our genes will help us to remember through our parents' lived experiences and their lived experiences how big to start the amygdala, and amygdala size determines how fast it activates and whether or not it's going to be like ding, 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 danger, danger, danger. So that's just one thing. Also, repeated activation of the amygdala makes it more hypersensitive to stress over time as well. So a patient who's, maybe comes from a family that didn't have that intergenerational piece, they come out the womb, they're ready to rock and roll, but life circumstances have activated again and again and again to the point where there's also a lot of communication happening with the nervous system at this point. But essentially, if we're never feeling safe, it's because the amygdala is constantly on guard and constantly sending signals to the nervous system to be on alert. Does that
Right. And
help
I
answer the
guess,
question?
yeah, no, I guess what got me thinking about is if I guess if their amygdala is constantly in a heightened state, their capacity to experience pleasure, right, is also reduced, right?
Correct.
Hmm.
Correct.
Yeah. So,
No, that's
hmm.
wonderful deduction. Because it's hard
Yeah.
to experience pleasure and to feel nice when we're constantly in a state of panic, right? And so this is where not everybody is created equal. So if we think about terms of susceptibility to addiction and addiction, again, there's a lot of argument as to like, well, if it's a disease, where do I get it, right? Is it genetic? Is it experiential? I guess the answer is kind of like yes, it's nature and nurture, or at least as far as I can tell from the work that I've done and the research that I've done. So if we're talking about it, we're just going to use your example, please, about a patient who is hyperreactive to stress, never feels safe, right? Um, then they're going to be, hanging out with some friends in a social environment, no, nothing crazy. And everybody is going to do, let's start with something pretty benign, legal right now, cannabis, right? Everyone smokes some weed. Everyone gets kind of high, but your patient not only gets high, but also experiences a moment where the amygdala slows down, the nervous system slows down. And so not only are they being elevated, but their physiology is also being braked for them, right? And what that's going to do is tell the mesolimbic reward system that cannabis is now 10 out of 10 top shelf, right? We like this. And we like this being from a subcortical region of the brain. Not because we're getting high, but because it takes a high metabolic cost for the brain and body to be on high alert all the time. It stresses the nervous system out. Inflammation, cortisol, all sorts of physiological struggles associated with being in a constant state of hypervigilance, right? And if cannabis can come in and turn that off, right, my association on a subconscious level is going to be much greater than somebody else who's just smoking cannabis for the sake of smoking cannabis and they enjoy getting high, right? So immediately our brains are going to be reacting to it in two very different ways. So I'll kind of just pause on that for a second. This is where I get
Yeah.
real passionate and excited. Any other questions or follow-up comments? All right,
Well, I guess I have sort of one more question, which is, are there people,
please.
so I would assume there are people who are susceptible to addiction because it calms their amygdala down,
Sure.
in addition to making them high. Are there people who are susceptible to addiction even though their amygdala is not uh,
Mhm.
in a constant firing state as well?
I would say yes.
Mhm.
I think the amygdala and stress is one element of a variety of subcortical features that can be supported by substances. And it's weird to say supported by substances, right? Um, for instance, if we look at someone with chronic pain, for instance, and their opioid system is constantly being activated, they're going to bring out a higher susceptibility to opioids, for example. So while
Mm.
some person that gets a lot of amygdala regulation from certain substances, that's going to be their drug of choice, essentially. Other folks may gravitate to other substances that do other fun subcortical things to help with their brand of issue and problem and association. And then there's also just the factor of ongoing repeated use continues to create changes in this mesolimbic reward system that will bring about the phenomenon of craving. So long-term repeated use, a lot of people say, well, I just do it because it's fun, right? I just like to do it for its fun. It's like, well, what else? Okay, fun because you're going out with like your friends, right? And you're in all these engagements, and there's a lot of high social value in using substances. And so, what happens if you're not using substances in those spaces? And usually it's like, oh, well, I struggle with X, Y, and Z, and so there can be it can be individualized, and that's why there's really no say. Like, I never really fallen into the camp of like, well, this is exactly why everyone struggles, but it kind of paints the picture or allows us to begin questioning why certain people struggle with certain substances and help us understand the complicated quilt of their life that led them into these spaces and created the vulnerabilities in the first place, right? Rather than just falling into the essential dare model and said, well, you shouldn't have done it in the first place, or you did it too much, and so now you're hooked, right? Two people, similar backgrounds, can use the same substance, one becomes addicted, one doesn't all the time. So it's the
Mhm.
ability to become really curious as about where it's coming from and how it's affecting people.
Right, so you're describing a primary and a secondary. So the primary is, what does the drug do for me? Why do I need this drug? Why does my brain love it so much? And then the secondary is the problem that's created by using it all the time. Then that becomes addiction becomes this primary issue. Mhm.
Yes, I would
Mhm.
stand behind that. Dre, did you have a question? No. And I thought I saw it turn green for a second, right? So absolutely. Um, and there's two spaces when you're engaging with someone struggling with a substance abuse issue. A lot of the times we're meeting them in the acuity, the acute in the moment. What is the issue right now? And that would fall under this almost the secondary category becomes the first category. What are you struggling
Mhm.
with right now? What is your withdrawal effects? What are the consequences going on in your life? How are you struggling? Are your social systems crumbling? So there's all sorts of places. You almost have to start with the external manifestation of what the problem is. And hopefully, as we go long term, we can begin to break the associations that are wrapped into this, right? And there's a
Mhm.
number of other pieces at play here where we start to add, talk about the default mode network. The default node network of the brain is a complicated brain region that essentially helps us to narrate our sense of self and identity. It activates a lot in a state of rest and kind of helps us to like place ourselves in the context of situations. And so as these experiences are happening, narratives begin to form within who we are in relationship to substances. So you're dealing with the physiology, but you're also beginning to blend it with a sense of identity that can also be a challenge in this, because that sense of identity creates a story around substances, what they mean to me, about people who try to get us to stop them. So the narrative around addiction as these things are activated can be really, really tricky and challenging. And just the last piece I want to add about the mesolimbic reward system is that if the brain becomes activated in a way that the mesolimbic system knows drugs will help with, even if there's no drugs around, right? So we're not talking about seeing it physically. We're not talking about physical triggers, right? We're talking about mental and emotional triggers. We're talking about physiological triggers that can influence that phenomenon of craving. The mesolimbic reward system, um, well, partly through the somatosensory cortex, it'll register our bodily sensation and what we're feeling in a moment. And it will say, oh, I know what will help us with that. And it'll begin sending signals to the front of the brain and into the area, right? Thought, logic, decision making, every part of the cortex will begin to actually release dopamine and other neurotransmitters in the front of the brain, where patients will actually report starting to feel the effect of the drug before they have taken the substance, right? And so again, this is a very physiological explanation of the phenomenon of craving. This isn't coming from willpower, that the part of our brain that should be telling us to not is starting to tell us to, right? And there's a region in the brain, the orbital medial, which sits right here where this information is coming through. Again, it should be the part that says, hey, don't do this. But because there's a sense of discomfort arising with it, it actually begins to go, hey, we do need this because we want to feel good right now and we currently feel bad, and this is a way to do it, right? So bare bones run through of sort of the phenomenon of craving, part of the disease of addiction, why it's so tricky and difficult to snap and break. And again, there's a lot of more nuances and other places I can go. But so far, are there any sort of questions or associations or anything further I can add about this process?
Hi, can you hear me?
Oh, now I can. Yes, ma'am.
Oh, okay. So my name is Dre, and I don't know if you can see me. I've
Okay.
had trouble with the app. I'm in my car.
Hmm.
So
Oh, totally.
um, first time I've used Zoom in the car before. Anyway, I'm glad to be here.
Thank you.
Very glad to hear this presentation. It's it's kind of synchronistic because I happen to be in a program, a graduate certificate program for psychedelic assisted therapy through Pacifica Graduate Institute. I'm extremely interested in getting back into nursing through this window, and so your
Wonderful.
presentation is of great interest to me. I have a special interest in addictions because of my own history with it,
Hmm.
my family's history. And I just want to say that I concur with everything you're saying. I also would like to add, and I don't know if your research bears this out, but anything that we find comforting can turn into an addiction. It does not have to be a substance.
Right.
It can
That,
be a behavior
mhm.
that triggers that reward in the limbic system.
Absolutely.
Yeah. And so I'm excited about the possibilities for ketamine assisted therapy for these kinds of things because um, the behavioral change models that attempt to address addictions just don't work for a lot of people.
Mhm.
They do not understand some of their self-destructive behaviors, perhaps because it seems to be related to the unconscious. And it could be trauma that's way down deep that's never been dealt with. That's something that I suspect is going on in a lot of the people I've worked with. And certainly I've seen it in my family. What are your thoughts on that?
Yeah, I think that you and I are akin in that belief. I think, what I'm trying to help understand here is that these subconscious drives are understandable. They are accessible. It doesn't have to feel like some mysterious place that addiction lives. We can actually kind of find it, and we can locate it, and we can work with it. And then what you're also describing around behavioral addiction and other means to engage are 100% accurate. So yeah, that's definitely a piece of the puzzle. And if I had a couple more hours, I would get into all of them, because what I really like, and this is a nice transition, so thank you. What I really love is ketamine's ability to directly engage these regions of the brain, loosen up long-standing neural pathways, and assist in the way this operates reshuffling itself
Wow,
so
that
that folks
that
don't
really,
hear.
yeah,
Mhm.
because the behavioral focus, let's say, now I am not knocking AA or NA, I would never do that. The community support of these organizations is life-saving, but they require that people follow a set of paradigms, guidelines, and
Sure.
some people have great difficulty doing this. Plus, if there's any kind of, um, I don't know how to put it, I'm just going to use the word shaming involved in any way, shape, or form. Typically, what I've seen is that people retract, they shut down, they move away from wanting to go there. Do you know what I mean?
I do. I do. Well,
Yeah.
fun fact, shame is painful. Part
Yes.
of how shame developed over the centuries as a societal tool is to help push us back into the herd, right? So it doesn't come from a inherently horrible place, but part of
Right.
the mechanism by which it does that is to enact pain, and we feel it. We feel shame. We feel it. It hurts. It doesn't feel good to be in shame. What does that do to folks struggling with addiction? Well, why? Glad you asked. It activates mesolimbic patterns that help people to regulate pain. Fun fact, pain, emotional pain and physical pain are actually rooted on the same neural pathways. And
Mm,
so again, from a physiological level, our brains struggle to identify the difference between being in emotional pain and being in a physical pain, which again, ta-da, substances, you take certain substances, it deals with both. So I think
right.
shame, belief that we are shameful or folks are shameful for having struggled is deadly. I guess is the best way to
Yeah.
put it. It's very, very deadly.
Okay.
So, right, the
Thank you.
antithesis.
Yeah.
Yeah, you're welcome. And what is the antithesis of shame? The antithesis of shame is love. And so, how do
Mhm.
we bring love? And not only how do we love our patients, but how do our patients love themselves, which is tricky.
Exactly. Yes.
So, I'm gonna switch gears now just a little bit. I'm gonna get into some of the pieces of ketamine, and then I'm gonna make sure to layer it back together, right? Um, Ketamine is a psychedelic. However, it is also a dissociative anesthetic. It's been used since the early 60s. Um, Fun fact, it's a cousin of PCP. That was a little too whoa for folks in the operating room, so they ended up with ketamine. Um, Most folks who have ever been under general anesthesia have experienced ketamine. However, the dosing that they use is so much higher than the dosing that is utilized for ketamine assisted work, that it creates the amnesic effect where people don't really realize or experience terribly much. Um, Ketamine can have varying impacts at varying route levels of administration. And depending, well, as you administer ketamine and as it binds into the system, it is known as a glutamate antagonist. And so it is activating glutamate receptors, and it has a particular affinity for binding to glutamate receptors in the limbic system, right? So the limbic system sort of starts to get flooded with ketamine. As the glutamate acts as the gas pedal of the brain, it helps to inspire electrical activity to help different brain regions communicate together. When a certain neural network or certain set of neurons is firing rapidly over time, the brain is saying this is something that's really, really important, because it's requiring a high level of metabolism, metabolic energy to engage right now with these neurons. And so it says, okay, we need to activate so that we can kind of make change, right? Repeated behavior over time wires neurons together. The adage, neurons that fire together, wire together. I believe that's another Dan Siegel phrase. It's true. And how we're talking about the way different brain regions wire and begin communicating. Because what I described earlier is a number of different brain regions that all have their own separate function. However, they all need to talk, they all interact, they all relate. And they do that through the firing of electricity through different neural networks. So again, think about that sense of identity, that sense of self. I am, stick on, stick on that shame, right? The feeling like I am bad, right? So all of a sudden there's a negative feedback loop from this belief that I am like bad, maybe negative actions, negative decisions. It's creating shame, it's activating pain, it's doing all these kinds of things. And it gets stuck on a loop. That neural pathway will then actually like myelinate itself, which secures the connection. Um, Anyways, we're trying to break that, right? So if we feed a bunch of ketamine into these systems, the neurons get super fiery, they get super excited, and the brain says, I need to prepare for change, right? And from a neuroplasticity space, we have now created a fertile ground for plasticity to enter. This is done in a number of different ways. Nerve endings will begin to grow, like strengthen, double. You'll see it in different synaptic connections. Another neurotransmitter called BDNF, or brain-derived neurotrophic factor, enters the picture, which also strengthens cells and helps to solidify changes, right? So essentially, we're taking hardwired regions that are communicating to one another, and we're sort of loosening them up, right? And once we're in this sort of open state, this is where the assisted psychotherapy part steps into the picture for ketamine assisted psychotherapy. When I'm conceptualizing the use of KAP for a patient with substance use disorders, my intention is to use it to create space for new experiences, create space for something new. And with the added benefit of being neuroplastic or having a window of neuroplasticity, the work that I have been doing with my patients, or the work that I will continue to do with my patients after the ketamine experience, has an opportunity to wire together and solidify at a rate much more rapid than without having just had this sort of fertile experience to create this opportunity, right? So I'm not saying that ketamine in itself can be a treatment for addiction. My argument would be that ketamine can help create an opportunity that addiction treatment work can be much more effective at a much more rapid rate. There's other aspects too about the way in which it's acting as a, I don't want to use the fertilizer, it feels cheesy, but it's also creating an opportunity to strengthen neurons that may have been degraded by long-term substance use, right? So we're able to actually take connections, old connections that may be worn, maybe burned out, taking neurons that may be faltering, and actually creating an opportunity with this medicine to help them bolster, and then also to connect in new ways to help inspire new appropriate action, new sense of self and self-identity, right? A lot of research with ketamine shows pretty spontaneous pro-social effects. What do all the treatment programs, be it AA, IOPs, inpatient, work with? Groups, people, getting comfortable with people. And it seems so simple, right? You want to recover from addiction, get with a group of people, get your support. Well, typically it was people that created the first break in your social systems that created a vulnerability for addiction to present itself in the first place. People tend to be the ones that hurt us, and then we get to a place where people become the ones we need to help us. It was a very vulnerable moment for people to present in that space, right? Um, Ketamine, other mechanisms of action, it also works on the opioid system. Mu and there's one other opioid receptor, and I'm not super sure on the specifics of how they operate, but essentially that is responsible for the euphoric feeling that can come when under the influence of ketamine as a psychedelic drug. This can also help in chronic pain scenarios, or people who are very sensitive to pain. Again, either emotional or physical pain, and can help to like re-bolster and like replenish some of our inherent opioid system. Again, we have an inherent opioid system. Oxytocin, endorphins, they're all acting off of our inherent opioid system. That system gets degraded over time through long-term use. The withdrawal effects of opioids, for instance, create a massive, like we don't have the inherent capacity to self-regulate our feelings. And the opioid system is also responsible for temperature. It also plays a role in metabolism. So all these systems are sort of like, wow, what's going on? And research has shown that ketamine can be an effective tool to help like mitigate some of the impacts and speed up the withdrawal process. Um, Again, not necessarily inherent on its own, but in a safe clinical environment, being monitored with dosing over time. All of these things are really, really important. So again, it's just not giving folks ketamine. It's how you give them ketamine, why you give it to them, and the care and supports that are built around it. Because again, folks are in a really vulnerable situation. Um, just like any behavior can become addictive, right? I mean, ketamine is a substance that is playing with opioids, providing a sense of pain relief, euphoria, creating a break from reality. Anything that combines euphoria with mild disassociation really seems to have an affinity for addiction. Um, Now, so yeah, that's something that needs to be considered. And part of that is also when and where in the treatment process does a patient become a good candidate for KAP work, which really is an individual process. So really knowing what the levels of care are, really knowing your patient, really knowing how far along they are in a detox process, what the fall off will be if they were to just stop, what options are available to them, and how do you fit it in, right? It could be really helpful for a pre-contemplative patient. Again, as long as they're not taking any other substances that may be a risk factor for physiological health. So making sure that they're physically safe, they're not at a place where they're in danger from the drugs that they're doing, and they're really struggling like, do I want to, do I not want to? Again, that narrative around why we like it and what does it do for us, combined with introspective experience that allows those patterns to loosen, can create a fertile ground for moving someone from a pre-contemplative to maybe a contemplative stage for recovery. Early recovery, again, you're assessing for safety, physiology, making sure that there's stop gaps involved. It can be valuable for early recovery. Again, like there's a risk ratio, so maybe even you could even look at it as a harm reduction tool in certain aspects. But how are we helping them get through this process? Or the craving is really, really bad, or the withdrawal is really, really bad. Can this potentially be a means to help support them through that? And even we're talking about like if you move forward into like long-term recovery, folks may be reaching stuck points. They may be wondering what's going on. Maybe other emotional barriers have arisen. A lot of the early drafts with AA talked a lot about emotional sobriety, and folks in long-term recovery can burnt out. There'll be a lot of trauma in early recovery. A lot of folks don't make it. So a lot of people you start with may not be around after a few months, a few years. and getting to that place where you're starting to kind of question. So again, these can be tools to help inspire that sort of introspection across the span of addiction treatment. Um, and yeah,
Yeah, can I,
but again, please.
yeah, it's like a really complex thing because that, Dre mentioned AA, and the whole culture of AA is really all about like not getting high, right? And right, and then somebody like you or me comes along and is like, hey, there's this drug that gets you really high and it can really help you, right?
Yeah,
Right. And but it really can't.
that's the wild
It's
part.
right. It's yeah, yeah.
So
Mhm,
but being able to
mhm.
have that nuanced conversation is super important. And some of the way I frame it, right, clinical versus recreational, and this is, I found this to be helpful for my own conceptualization and for others who may be curious. Typically the association with like getting high is to escape self, right? I get high away from myself. I'm taking a substance to move away from something, right? And in this environment, the framework, what I'm asking all is you're using a substance to go into it, right? We're actually using this to move towards the thing that's causing the discomfort rather than using it as a means to go away from discomfort. So yes, it's going to get you, I mean, high by the essence of the word, but it's also going to get you deep. It's also going to take you in, and that language around mind manifesting being the root of the word psychedelic. It's the ability to experience your own inner workings in a safe way to help you understand what's actually going on, right? And so it's almost like framing it that it's not, again, it's not a miracle, it's not magic, but it can be a very effective tool for you to understand yourself and how you're stuck in this cycle of addiction in a much more concrete, practical way. But it is, I mean, yeah, it is controversial. It is a nuanced conversation. Um, yeah, so when
Yeah,
we're just starting, yeah.
yeah. And I guess what I'm interested as a cat practitioner is, okay, so somebody calls you and says, how do you, who has an addiction history or is and obviously all these things matter greatly. How do you, and maybe this is another training, which is how do you, right? How do you assess um, all the risk versus reward, um, yeah, factors?
Yeah, I mean, I
Hmm.
think I'll do my best to take a stab over a couple minutes, but also shameless plug, training is coming soon. Um,
Uh-huh. Uh-huh.
early to mid spring 2025, I'll be collaborating with Interpath to do one of the first trainings in this area. And we're going to include a lot of ketamine for trauma and ketamine for addiction to be integrated into this. So, because again,
Oh,
it
that's
is.
exciting.
Yeah, thank you.
Uh,
We're very excited. We're very
Well,
excited about
I just can't say enough good things about what I'm seeing coming forward. When you think about where we've been in terms of treatment modalities that are available for these types of really ingrained complex issues and how stigmatized they are. I mean, this is game changing for so many people. I don't mean to interrupt your lecture, but I do have a question before we leave.
this, man.
So
Yeah,
anyway, I'm just excited.
I love it. No, I'm excited too. I share your enthusiasm. Um, again, I could keep going forever about this because I do feel like it can be a game changer. And if you look at
Yeah.
the environment, psychedelics are coming whether we want them to or not. Be it ketamine, be it MDMA, be it psilocybin, DMT. Maryland just approved the bill to look at mescaline too. Like it's coming. And so I think it's an interesting opportunity right now to really get together and start asking these questions. Like,
Well, and there, you speak to the potential harm, and Shlomo, I hear that in what you're saying too. Of course, these are substances, but taken out of their context, therapeutic context or a safe context, of course, any substance can be dangerous. But if you look at the overall um, harm potentiality across the board, what you find is that alcohol is by far the most dangerous substance to our bodies, our society, etc., bar none. And it's totally legal. So
yeah,
I have a problem with that. And these medicines, the plant medicines in particular, were available for thousands of years to cultures that knew how to derive a great deal of help from them in very safe ways. And our governments, plural, basically shut all that down and took it away as though we had the right to do that. So now we're coming around to understanding that that's probably not okay, and what we're seeing that with what just happened or has been happening with cannabis, finally we're decriminalizing. And so that's a really huge step. And these modalities are so we're just right on the frontier of all of their therapeutic applications, I
which
feel.
I think leaves us with a sense of responsibility. And I
Yes,
think while there's a level of responsibility with working with psychedelic medicine or ketamine for the treatment of any mental health disorder, I do think there's a level of humility and reverence that we as
absolutely.
providers bring into the space in terms of addiction, because that line of therapeutic, recreational, if we're not really careful and if we're not checking our own biases and we're not assessing properly with supervision, not just if it's good for the patient, but what is their social support? Because someone who
Yes,
is ingrained in it, last thing you want to do is encourage them to do something that all of a sudden they lose their entire support network. Um, and if you're looking at it, but at the same time, I think it's so worth exploring because with or without ketamine, patients are dying by the droves. People are dying of substance use issues right now, every decade.
exactly.
So it does become a question of like, well, what we've been doing isn't helping enough people. The net isn't wide enough. Like there's a wide net, but the net has too many holes, right? So how do we close that? And this feels like a possibility to do that. Again, like right patient, right time, right procedure and protocol. And again, it becomes a matter of just conversation, consultation, being able to look at that. And I would like to share a couple of just really interesting case conceptualizations that really got me, because when I moved to Interpath, it was like I'm getting away from addiction for a little bit, right? Like a decade in the trenches doing substance abuse work at all these different levels, running programs, direct patient care, everything. It was I needed to step away, right? So I really wasn't going there to pursue like this intentionally. And a couple patients came my way almost serendipitously around the same time, and none of them presented with substance use as a primary goal or target. Um, they came for a myriad of other issues, right? They maybe have mentioned in passing that they drank or used cannabis, whatever, right? And I remember like clockwork. It was almost the same day these same patients came in, and one after the other, after about two CAP sessions, decided to tell me, A, that their use was much more severe than they reported to me, and B, they hadn't used since the first session, which at that point may have been like 2 to 3 weeks, right? Just boom, boom, boom. It was worse than I thought, or worse than I told you, and I'm not doing it anymore, and I really don't feel like it. And the other asterisk was like, and I don't really get it. Like, I just don't want to. right? And it led to much more open conversation, much more open discussion about their use history and how they ended up in the place that they were. But patients smoking cannabis for decades suddenly deciding that they really want to not. Multiple patients beyond them suddenly coming in, being like, yeah, like I wanted to quit cannabis. I told you I was going to quit cannabis. It was harder than I thought. So I went to some marijuana anonymous meetings. Like it used to take me
Okay.
months to like convince a patient to either stop or go to a meeting. And here I was doing my protocols with people, and they're just doing it on their own. They're just coming back and telling me how it was. I'm not telling them what to do or what they could do. Like
Unbelievable.
chronically
Mhm.
depressed folks getting on the computer to look up meetings and going by themselves to like get social support. And I was just floored, right? I was like, oh my
Wow.
gosh, there's something to this. Now that's not everybody's situation, right? But it happened with enough consistency and has continued to happen where I'm like, okay, this is more than just a theoretical approach, right? And again,
Mm.
there's a lot to it. Like you've been smoking cannabis for 30 years, like you have a narrative and an identity around what it means to smoke weed, right? So it's not just not smoking weed, it's your whole sort of identity, your routine throughout the day, all these different things that can really feel stuck and titrated and dense. Start going through this process. You add the right level of psychotherapy along it. You start working on different targets with the medicine. Next thing you know, people are feeling open. They're feeling free to change, empowered to make different decisions, and a willingness to try, right? Again, separating that sense of identity from productivity and being right, like a willingness to go to a meeting and not like it, right? A willingness to try to stop coming off alcohol, even though they know it's going to like hurt, right? So there's a level of like a increased willingness to tolerate discomfort, an increased willingness to connect pro-socially. And this is just happening beyond the targets.
Mm.
So yeah, from there it's
Yeah,
like okay, I'm sold. This
yeah,
is interesting.
totally. I mean, I always think like people just want to feel good. That's the bottom line. Like, and drugs, having a habit, that's like a really shitty way to live. Like you feel good some of the time and you feel really shitty other
Right.
times.
Yep.
So if you help somebody find an experience of well-being, yeah, they're not going to choose something that's going to, it's much better. It's a better, well-being is just a better drug than a healthier brain is a better drug than anything that,
Yeah.
you can buy on the street. So it's just meth.
I used to tell folks there's no down from a sense of peace, right? And like
Mhm.
contentment doesn't really cost anything. And that was something that folks really resonated with, like content, like there's no like drugs make you feel good, but they don't make you really content. Right. And so people finding a way to be content with their lives. And I think too, back to this idea of escapism or moving away from a problem through substance use, when you have a life and you have a self that you don't want to escape from, that you can sit down on the couch and like buddy up with, then there's no need to
Mhm.
escape what's going on, and that
Mhm.
return to a sense of peace and contentment as you are. Um, and so again, like really hammering home too that KAP, it's a collaboration, right? This is me, this
Mhm.
is you, this is the medicine, and the three of us are working together here. And every step of the way, empowering patients that it's the work that they're doing, the way that they're talking to themselves, the way that they're facing their problems, right? I mean, so many times in a session with KAP, like, what do they meet? Fear. What are we teaching them to do? Go towards it. What do they meet? Sadness. What do we teach them to do? Go towards it. And like clockwork, patients who are able to approach and face it, what happens? It transforms. Behind it is a sense of peace, right? Then
Mhm.
we encourage that. Face the discomfort. You sit in the discomfort and it gets better. And we're able to facilitate an experiential activity of that essentially. So it's not just me telling them anymore. They're doing it right there in session, and then they're able to repeat it and keep going until that becomes part of their state of being. And I think
It,
that's where the magic really new state of being, you
that
know.
that right there, and the fact that it happens so much faster than the traditional therapeutic alliance allows for, And with the AA or NA groups, that process is still valid. However, it's very, very slow, and the ego is still in the way. I see these modalities as helping the patient eliminate sense of self temporarily. In other words, like if they were being put into neutral, like a car driving through a car wash in neutral, and all this stuff is going to pour over them. But they're going to come out on the other end and they feel safe thanks to the therapeutic support system that is accompanying them. And that's hugely important, as we know. And as a result, they can see what, what is holding them up or not holding them up. And the fear just starts to melt away. If I were to name one thing that stands in the way so much, it's unnamed fear that people aren't even aware they have around letting go of a substance or what's going to happen to me as a result of XYZ.
I agree. I agree. So again, it's exciting stuff. I'm gonna real quick just share my screen. On here is a few different ways to contact us at Interpath, info@interpath.com, or on our website. There's a number of different ways to get in touch with us. Again, stay tuned for the training that we're going to be launching, because there's so much here, and I'm really going to do my best to get into it and be able to explore those nuances in the spring. But again, in the meantime, please stay in touch. Even if you just want to chat, I love this conversation. I'm super passionate about addiction. I'm super passionate about KAP. The two come together, I could probably talk forever. So careful. But thank you so much for coming out tonight. I really appreciate it. Thank you to Interpath for allowing me to do this and hosting the event. And I hope to hear from y'all. Hope to hear from y'all soon.
Thank
Thank
you
you.
very much for having this.
You're very welcome. Thank you for
Thank
coming.
you.
you.
Good to connect. Bye-bye.
Well,
Bye-bye.
bye-bye.